What's up? What's up? What's up? It's another episode of Diabetics Doing Things, another episode in the first issue of the Diabetics Doing Things Creator Zine. I'm really excited to share this interview with you. It's a little bit vulnerable for me because we're going to put my data on display. What was that like, Eritrea, like hearing and seeing my data like out there for everybody?
I feel like I know you better than I've ever known you before. It's really weird to like look at someone's intimate data. Like, I don't know. We've been talking a lot about vulnerability exchanges these last couple of episodes, and I really appreciated you just absolutely opening up your lab results to all of us as people with diabetes to just kind of really see what those ranges look like and what levels matter and things like that. But I can imagine that for you, it must have been a little, I know you like to be perfect. I know you like to be the best at everything you do. So I can't imagine what it was like to be like graded on a public scale.
It's interesting that you say that. You're right. I am like that. I try to do my best all the time and I get, really upset at myself first, whenever that doesn't happen. So I think on one hand, I do hear you and I think it is challenging. However, my results are really good too. So it's sort of 6 one way, half dozen the other, where yeah, I did open it up, but also my numbers are good and I feel good about them. So my feelings are reflected through it. I don't know. It wasn't as difficult as it could have been. If my A1C had been a little higher, or if I had had some, results that I wasn't as happy with, then I think it would have been a different story. But I want to give you guys the full picture. And this is like, literally my life insurance exam metrics. Like there's no, I don't know, switching, there's no hiding. It's really cool. And, one of the reasons that I think it's super excellent is because we got to have Dr. Joshua Miller, a person with diabetes and the director of diabetes, medical director for diabetes at Stony Brook Medical Center in Stony Brook University. So he got to join us on the call and kind of review what it's like and what people with diabetes should know about the labs that their endocrinologist requests on a regular basis. And not only what do they mean and what's behind them, but how they can take action to either make adjustments or improvements and learn what they mean. We've never had an endocrinologist on the show talking about this. And that's something that was not a conscious choice from me, but it was just over the years, it never really came up. And as we were thinking about the questions that people with diabetes have and what we could contribute to them, one of the things that came up was, well, I have to get these labs, but how much dialogue am I having with my doctor, with my endo, with my care team after them or before them, or what can I do about it? And I was really curious about that. So I was really glad that Dr. Miller gave us his time. And, also, honestly, just slam dunk after slam dunk on this episode, pardon the sports puns, but Dr. Miller just, it's such a cool thing to hear a person with diabetes talk about caring for patients with diabetes at the same time. I felt very seen. I felt like a lot of the narratives that, people with diabetes really like and are really looking for from a care provider, Dr. Miller embodies those. So I'm curious to know what it was like for you kind of listening in this morning.
Well, so I've never really taken my lab results and really sat with my doctor and been like, please explain these to me. So it was really interesting to understand what levels actually matter, because there were some ranges on your labs that I was like, oh, those numbers look weird. Like that's kind of concerning, but I'm not a doctor, right? I don't know anything. So I think that the average person with diabetes, when they look at their lab results, they're not really even looking for anything. They're just sending it to their doctor to later be talked about. So I really appreciated today's conversation because it really gave me some insight onto what are the things that I need to be asking my doctor about. Where are there some places that maybe I could improve or make changes, or if there's some familial link to why I might have a higher cholesterol level or whatever it might be. So I thought that it was really insightful. I learned so much about how our bodies work just as people and what those numbers look like. And I think that you're right when you say that when an endocrinologist who has diabetes and treats people who live with diabetes talks about it, it adds a layer of understanding and empathy that you don't really see on an everyday basis. So this conversation felt really, really special. And I feel lucky to have been there. It was cool, Rob. I liked it.
Oh, I'm glad. I think you guys are all going to enjoy it. Before we get into the conversation with Dr. Miller, though, I think this is an important distinction, and one that I think is one of the many reasons why we have not had a lot of medical providers or endocrinologists on the podcast prior is because, make no mistake, this is a disclaimer. I am not a medical doctor. Diabetics Doing Things is not an organization that provides advice or treatment options for people with diabetes. We are sharing stories of people. And today, Dr. Miller digs into each of the tests, and we talk about ranges and things that you could do to influence them. But please do not make any decisions caring for yourself or your diabetes or any of these labs without first consulting your doctor or your care team. We are not liable for that. We're not saying to follow anything in particular. We're just discussing the realities of getting your blood work done as a person with diabetes and what that looks like, whether that's 3 months, you've been initially diagnosed, or right at the beginning, or it's 6 months, or it's a year, or you haven't been to the endo in a number of years for one reason or another. I think this is an episode that's really accessible and honestly speaks really straightforward about some really complicated tests. And I think that translating that science into layman terms was something that stood out to me with Dr. Miller. And I'm like you, Eritrea, I have not spent a lot of time with my care team digging into what I could do to influence the results of these tests. Part of that is because I think when I get in the chair at an endo's office, I feel rushed most of the time, and I feel kind of anxious to like get it over with. And I just kind of follow what they want. But I'd encourage anybody who's listening to this to take an extra 5 minutes if you can and try to talk to your endocrinologist if you have questions about your labs and what they mean and what you can do about it. So with all that said, please enjoy this Diabetics Doing Things Creator Zine Issue 1 interview with Dr. Josh Miller.
So what does the book say? What do the standards say? And as a subspecialist, I see patients from all parts of Long Island, all different walks of life, all different backgrounds. And we see a lot of variation in the community about how people with diabetes traverse the healthcare system and what different doctors in their lives do for them and with them. But we tend to focus as much as we can on the standards, and really is how often does a patient with diabetes need to go to the lab and get blood work done? How often do they need to get their A1C done? And what will that data do to your life with diabetes, and how is it going to inform how we help you to achieve your goals? There are some doctors who encourage/force their patients to go for blood work every 3 months. I can't think of any standard, at least in the world of diabetes and its complications and preventing complications, that would have a patient going to get blood work done every 3 months.
What are we looking to measure, and what are you, specifically with your patients, looking to measure on a regular basis for people with diabetes?
Yeah, so right, it's a question of what the goal is in doing the measuring. So A1C obviously is a core component to people living with diabetes and clinicians who care for people with diabetes. Although even now, these days, I find myself not relying as heavily on A1C as I do, for instance, in time and range when using continuous glucose monitors and devices like that. So, an A1C is going to help you to understand how well we're doing in helping you to control blood sugars, and to help us to think about whether it's an insulin regimen, or in someone living with type 2 diabetes, a medication regimen and the like. But the second component, and really the largest component to why we do, in most cases, annual blood work for patients with type 1 diabetes, is prevention. So ultimately, what are the types of complications patients with diabetes can develop? They don't always develop them, but what are the types of complications that people develop? And then how do we monitor for patients' risk of developing those complications? And then what do we do with that information? Diabetes is a marathon, it's not a sprint. So yes, we're focusing on today, tomorrow, and next week, but I'm also focusing on next year, the next decade, and beyond. So we generally think about complications of diabetes as falling into one of two big categories. One is microvascular disease, and the other is macrovascular disease. In the microvascular disease category, I'd think about things like diabetic kidney disease, diabetic eye disease, sexual dysfunction, erectile dysfunction, gastroparesis, things that would result from damage to the small blood vessels. And then macrovascular disease would be things like heart attack and stroke. So those are the ways in which we study complications from diabetes, as we categorize them based on those two big buckets. And then we think about how to lower someone's risk long-term in each of those areas of complication. I get asked all the time from patients, will I develop complications? And the answer is no, nothing's 100% ever. We have some patients who are living for decades and decades with type 1 diabetes, and they have perfect kidney function. Their eyesight is great. They have no damage in the blood vessels in the backs of the eyes and the like. And so, their complication burden is very low. And I have other patients still who, unfortunately, they have exquisitely controlled blood sugar. They're exercising, they're fit, they're active, and they do go on to develop some microvascular disease. So we're understanding a lot more about risk of developing complications, but the number one thing that I say to every single patient with diabetes when they're first diagnosed is, in 2022, if you do a reasonable job controlling your diabetes, like a B- C+ student, your chances of getting a complication from diabetes are less than 1 in 100,000. The number one preventive piece of information that I probably glean the most insight from for people type 1 diabetes especially is an annual visit to the eye doctor. Similarly, so why am I being sent by my endocrinologist to see my eye doctor every 6 to 12 months, depending? It's for the eye doctor to look in the backs of the eyes, do a dilated exam, and tell me, God forbid, have they seen any preliminary damage to the blood vessels in the eyes from my diabetes? How does that information change things? Well, if God forbid there is some damage, it may compel me to have a more significant conversation with an endocrinologist about my blood sugar control. Also, in the world of diabetic eye disease, we know from the eye doctors that the earlier you intervene and recognize any damage in the backs of the eyes, the better people do longer term with their vision. So that's, again, part of primary and secondary prevention and just understanding trajectory overall and how you might be able to change and impact that trajectory with your doc.
If you are newly diagnosed, or if you maybe just aren't as confident, or this is a very soft spot for you personally to discuss, how do you, what steps would you recommend discussing with your care team to kind of help you get more information, arm you with more, even just strategies of how to speak to different providers, or, when you get referred to a specialist, what questions should you be asking, or how can you, when you see, when you're getting a referral, what questions can you ask your care team to prepare you for that interaction?
I think that's probably the singular most important thing in terms of clarity for a patient to get to be their best advocate. So, if and to your point that you sort of scratched the surface of but didn't dwell on, but I can because I'm a physician, right? What do they call the student that graduated last in his or her medical school class? They call them doctor, right? So there are phenomenal, amazing diabetes doctors out there. And I'm humbled by their care and commitment to patients every single day. And there are others that perhaps don't do as much of their due diligence in helping patients along their journey. I think every patient, regardless of disease, and in this case, diabetes, is seeking a care team that makes them feel supported and that shares in their journey, whether it's a diabetologist, a primary care doctor, a nurse practitioner, a nurse diabetes educator, or certified diabetes education care specialist, CDCES. I think anyone can play that role, but it's that shared commitment to my patient's journey that I think, at least for me as a patient, has been the most meaningful. I've had docs in the past that were seemingly judgmental and very matter of fact, and then others that clearly took the time and interest in making sure that I was achieving my goals. So the first sort of do not pass go unless you've addressed this with your doctors across the board that I would offer any patient and family member is, what are your goals, right? And understand that your goals as a patient may be fundamentally different from your endocrinologist's goals. It's not that he or she does not value what you want to do as a patient. It's that I think it's a recognition of both sets of goals. For many patients, I would like them to take a cholesterol medicine, but for the patient, maybe they're laser focused on making sure they don't bottom out in the middle of the night with low blood sugar. Well, okay, so I'm going to triage the cholesterol conversation over here for a little bit. We're going to get back to that, but let's focus on low blood sugars in the middle of the night. Let's tackle that together. And then once we tackle that, let's get back to the cholesterol part of medication. There's no absolutism in cultivating a relationship with your care team over time. In my mind, it's sharing your goal setting and helping them to understand what's important and meaningful to you, and helping you to understand what the data shows that I should be doing as your endocrinologist to decrease your risk long-term, to help you live that high quality of life that you very much want to achieve.
As we talk about complications and we kind of address a little bit the stigma and maybe those bad feelings, how do those conversations happen in your office with patients who are maybe feeling really, really guilty? I know that when I found out I was having some issues with my eye, I thought I was going blind, and I just thought it was completely my fault. And when I finally saw the retinopathy guy, he was like, no, you're just in a race against the clock. So how do those conversations happen in your office? And what would you say to patients who have maybe developed some complications and are feeling really guilty?
Yeah. So Eritrea, I'm glad you used the word, the G word, which I use all the time. And I ask my fellows and students this all the time as well. Yeah, we talk about, and I started by talking about micro and macrovascular complications from diabetes. When in point of fact, I find that the most significant complication of living with diabetes, whether it be type 1 or type 2, is guilt. It's that we can behave in a way that is identical to our peers, and yet we are at greater risk of developing complications and may, in fact, despite that good behavior, still end up with a complication. And I have this conversation with patients with type 2 diabetes. I have patients who go to McDonald's 7 days a week and maybe don't make the best choices, but their blood sugars are perfect, their cholesterol is perfect. And then I have other patients who they eat the best diet they can and exercise 5-6 days a week, and their numbers are falling apart a little bit. And there's this sort of, well, why do they get to do that? And what did I do wrong to develop a complication, God forbid? I think that in and of itself is the biggest stereotype that we need to continue to chip away at. There's no guilt here. There's no, what could I have done differently? And it's as much as we can focusing on the positives as recognizing the importance of addressing the negatives. So, okay, I may have some bleeding in my eyes. What do I do now? Is it going to derail all my progress on, I get up every day, I check my sugars, I exercise, I go to work, I lead a functional, productive life every single day. I live life to my fullest. I go to sleep at night answering the question, yes, have I done everything I can today to take care of myself? And okay, I have some bleeding in the eyes. And despite all of that, I still develop bleeding in my eyes. What do I do here? Is this my fault? There's never any fault. When a patient comes into my office and the first thing they say, or they're compelled to say, is, Doc, I've been bad, I stop them hard in their tracks. There's no bad or good. You made a decision, and that decision worked for you. Let's figure out how we can support you in that decision. It's not, I had pizza Sunday night and my blood sugars fell apart. No, you wanted to have pizza because it was your kid's birthday party. So next time, what strategy can we use to help you to enjoy the pizza and not feel so guilty about it? I think that's a big part of the conversation to me. And so it's not, you're going to go see the retinologist and get a laser, a cautery, whatever the case may be. And how did you get to this point? And I told you, if you don't control your sugars, you're going to end up, that's an awful thing. And I would compel any patient who's in that situation where they're being made to feel shameful or guilty, falling into that stereotype of a complication from diabetes, to push back a little bit and make sure you have a meaningful conversation with the care team to explain how that makes you feel. Because how awful of a situation would that be if you find yourself feeling more shame and guilt about something that you really had little to no control over? And that's
Right.
the truth. And that's the truth.
I broadcast this episode as a chance for us to review and put me in the test, in sort of the test tube, so to speak, to look at some labs and how we might have a conversation, in a care team scenario. So we've shared the screen for those of you guys who can't see us, and I've got some labs pulled up, and I'm going to scroll through here. I see some cholesterol here at the top. Where would you like to start with these labs, so to speak?
So we can start up top, and we've already had this conversation, but for the purposes of your audience, I'm not your physician. I'm not providing you bona fide medical advice, but I'm going through these labs with you to help you to understand what we look at. So so we're looking at a fasting cholesterol panel. And I think the first thing I would tell patients in general is, when you should ask your doc when you're being given a prescription for blood tests, when you need to be fasting versus not, and why. And for me, the fasting criteria is really only specific to your lipid panel. And the reason for that is that diet, especially the meal the day before, can impact how your cholesterol panel appears when they actually run the testing. So, were you actually fasting for this test, Josh, when you had the blood done? That's
right. 22 years with diabetes. Looking back, if you could transport yourself back to 22 years ago, what would you tell younger Dr. Miller about your life with diabetes, and what advice would you give yourself?
Yeah, I think ultimately, especially at or near a time of a new diagnosis, the whole process of understanding the impact of that diagnosis long-term is very, very, very overwhelming. And I would probably sit down with my 19-year-old self and say, you know what, everything's going to be fine. Right. I think that all too often, especially amidst what is a particularly scary diagnosis to receive, and everyone's got their own story about how they were diagnosed and who they saw at the time and where they were they in the hospital, were they home, et cetera. But I think the universal there is people are scared. And I would go back and give myself a hug and say, you know, everything's going to be fine one way or another. And understanding that there is a pathway forward to leading a healthy, God willing, complication-free life. And I think establishing that framework at day 0 is so profoundly important, because blood sugar control, medication management, all these things are vital. But if you don't help patients to realize what the long game is and share in that long game and crafting a strategy to getting there, the other stuff matters far less. And you get caught up in the weeds. So, you know, yeah, I give myself a hug and say everything's going to be okay.